Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals, Inc.
Welcome to Understanding and Managing Schizophrenia in the Digital Therapeutics World, an interactive update brought to you by Medscape Education. My name is Christoph Corell. I'm Professor of Psychiatry and Molecular Medicine at the Zucker School of Medicine at Hofstra Northwell in New York, and I'm also Professor and Chair of the Department of Child and Adolescent Psychiatry at the Charité University in Berlin, Germany. What are the learning objectives of today's lecture? Well, we want to define the pathophysiology of symptoms associated with schizophrenia, prioritize current unmet medical needs and burden of disease in patients with schizophrenia when you assess patients, and also provide insights into ongoing developments in clinical research in schizophrenia, and also, and I think that's important and sets this program apart, the potential utility of digital therapeutics. So the future is here. We just have to understand it and see how we can utilize it in our clinical care. But let's get started with reviewing the pathophysiology of symptoms associated with schizophrenia as far as we understand it. Because as you know, all models are wrong, some are useful, and some have proven useful for us to also inform drug development. You know about many of the domains of schizophrenia. Bleuler, who coined the term schizophrenia, actually said we have to talk about schizophrenia in the plural. What did he mean? He meant that there are most likely different pathophysiologies, but also different phases of the disease. Because when you have different domains, not every patient will have the same symptom severity in each of the domains. Now, the first three are very commonly used and also at least talked about, not necessarily addressed in clinical care, and they are positive symptoms, negative symptoms, and cognitive deficits. Out of that trio, we focus a lot on positive symptoms. Why? Because they get people into trouble with the world. They get people into trouble with law, with also getting maybe agitated and having to be treated in higher levels of care. Also, the treatments we have at the moment are best at treating positive symptoms. As you know, we don't have anything approved yet at the moment for negative and cognitive symptoms, either as monotherapy built into an antipsychotic or as an augmentation strategy to augment the antipsychotic effect of the treatments we have. Now, there are also negative symptoms. They are defined by the 5 A's. There are 2 expressive negative symptoms, alogia and affective flattening. And there are 3 experiential negative symptoms, anhedonia, avolition, and asociality. The latter 3 are much more associated with functional impairment. And then the cognitive deficits have to do with the 7 domains in the matrix, and we'll talk about some more about individual items, but it has to do with attention, memory, verbal learning, executive functioning, as well as social cognition and executive abstraction capacity. But we also have motor symptoms, both as part of the positive symptoms, being disorganized when patients are catatonic, but also there were spontaneous dyskinesias even before antipsychotics were conceived. So there is a dopamine dysregulation even in the motor parts of the brain. And as we know, dopamine blockade can actually augment that problem, causing Parkinsonism, akathisia, dystonia, and tardive dyskinesia. And even if we don't think someone has schizoaffective disorder, people with schizophrenia can get depressed. And it's not uncommon for them to also have suicidal thoughts, especially in the beginning of the illness. So, looking at suicidality, hopelessness, depression, anxiety are also important components of assessing and addressing these components in people living with schizophrenia. But the focus of today's discussion is on negative and cognitive symptoms because they're under-recognized, they're under-treated, and we have something we can do now, but hopefully also in the future, to address negative and cognitive symptoms. But let's start with reviewing the pathophysiology. I mentioned already that we have this reduced expressive component, affective flattening and alogia, and the apathy reduced motivation component, which is asociality, avolition, and anhedonia. And they're in different parts of the brain. They have to do with the frontal lobe, but also with subcortical areas in the brain. And we believe that a lot of this signaling in the NMDA glutamatergic realm has to do with negative symptoms, when there's not enough glutamate transmission, which also might reduce synaptic plasticity. So here some approaches could be to improve the signaling by having a co-agonist of glutamate like glycine or D-serine remaining in the synaptic cleft, because it's a dual key lock. You need glutamate as well as a co-agonist, glycine or D-serine. We have problems with that psychosis development when we block NMDA receptors. That's ketamine-induced psychosis, which also has negative symptoms. So we know from that experimental part, even in animals, that that receptor is involved in negative symptomatology. How do you translate these terms into the real world? So what is avolition? It means reduced initiation and persistence in goal-directed behaviors, and it may be like sometimes misperceived as laziness. Oh, Joe is not interested in doing things, he's just lazy. Or he really has negative symptoms. That's where psychoeducation is so important, to also reduce stress levels at home, because we know that high expressed emotions can bring out dopamine in patients and lead to more relapses. So psychoeducation of patients and families can help reduce relapses. So unable to make plans or engage at family functions, or calling friends, being engaged with them is one example. Alogia means brief, vague, one-word answers only, and that may actually reduce the ability to interact with people because we have limited flow of conversation. Anhedonia means there is a lack of or reduced enjoyment, not only in usual activities, but the activities that the patient really used to like. So it's important to ask, what did you like in the past? And now, are you not doing it because you have lack of energy or motivation? Or is it because you feel blah, it doesn't give you the joy? Affective flattening means that this gesticulation, also facial expression that makes us connected to other people may be lacking, and then the outside world gets mixed social cues, and it may be awkward to talk to such a patient, and they feel awkward. And then there's asociality. It means either passive or active withdrawal, not being interested in being with people. And that, again, obviously reduces the social activity and also the joy or the connectedness that can come with it. Let's shift gears and look at cognitive symptomatology. So here are some of the factors that go into it: executive function, working memory, episodic memory, which is more like remembering what happened in the past, but also social cognition. Social cognition arguably makes us human the most. It means that you can read someone else's mind in a way by looking at them, listening to the voice and what they say, that you know their intentions, that you can have empathy, but you also understand what they may expect of you, so that there is a supple interaction and communication. And when you don't fully understand what the other may intend or mean, there can be misunderstandings. There can also be maybe paranoid feelings, and it can become awkward to interact, which then makes other people maybe withdraw, or the patient withdraws because they're frustrated by these really not very enjoyable or also functional interactions. And here again, different areas of the brain are involved. The hippocampus has a lot to do with memory, but also the dorsal lateral prefrontal cortex with a lot of the executive functioning, and also parietal cortex with language. So how does that then translate into domains and real-world functioning? So attention is clearly relevant. If we don't attend, we can't take anything in. So it's about responding correctly to targets and being able to block out distractors. So being able to read a book or even just a page that you remember what was in the beginning of the paragraph when you're at the end, or remembering a plot of a movie. Working memory has to do with 5 to 20-second retention of things. So let's say you're looking at a piece of paper and there's a phone number on it, and you don't have to always every 2 digits go back to that page. Rather, you memorize it and you just dial it. Verbal learning memory has to do with maybe going shopping and remembering the 5 items you should bring home, and you lost the piece of paper and you only bring home 2. Reasoning and problem solving has to do with the ability to change strategies. So when the bus schedule always runs the same, it's easy, but when there's a change, do I have alternative strategies? Speed of processing has to do with being able to type and respond motorically quickly, for example, at a fast food store or even when you have your cell phone. And then social cognition, as I mentioned, has to do with the theory of mind and putting yourself into someone else's mind and understanding what they may want from you. But now let's switch from the content and the pathophysiology to what it actually means. What do these dimensions, when they're present in patients, mean for their functioning? So what's the burden and the unmet need? And here, when there are residual negative symptoms, there is a shared and reinforced feature with cognitive symptoms. They're often subserved by the same brain structures and also the glutamatergic system. So often one comes with the other. But since when you don't have drive and the capacity that the cognition gives you being put into practice, that's what the negative symptoms are in the way of, then you have problems with occupational and education attainment. Social functioning is clearly impaired because that's part of the negative symptoms. Household integration, participation in activities, and that can lead to diminished quality of life, not only of the patient, but also of caregivers that may have a hard time then interacting with the patient or doing things that they used to like. And there can be goal-directed behavior that's decreased, and also, obviously, difficulties with executing the cognitive part. So here, again, shared features with negative symptoms leading to vocational and educational struggles. Negative symptoms are very tightly related to social interactions, whereas cognitive functioning is very tightly related to vocational and educational attainment. But again, the cognition gives you the capacity to do something, and the performance is still driven by absence of negative symptoms. So you could have an increase in cognitive ability, but if there's no motivation to do anything, you will not put it into practice. This can then also lead to social interaction when you can't read what people may want from you, or you have difficulties in the interaction when you talk to other patients, or to also people on the street, your family members. That can lead to daily living struggles and also challenges in remembering when to take the medication, or have I taken the medication. Self-care can be reduced. That can lead to self-criticism. I'm dumb. I can't do this anymore. That may be defeatist thoughts like low expectation for success. And then, again, the difficulty of bridging intentions into action. So how do we then engage patients to help them achieve their goals? I think one of the best things is not to tell them what they should do, but rather to ask. That's the best way to start a conversation. So one would be to understand what's important to them. We talk about this at the moment, not even in a recovery concept, but life engagement. What does life engagement mean? It means not only to be good at the 4 pillars of functionality: self-care, social interaction, leisure time, and work or school, but also to have a sense of belonging in your life, a sense of meaning, a sense of leadership, so to speak, and agency. And for that, as Freud said, the two pillars of happiness are work and love. And those are two areas where patients with schizophrenia struggle quite a bit. So asking patients what they want of the four quadrants, self-care or independence, social interaction, work or school, or leisure time, then let's see what is it that's in your way of getting there. So what do you hope to do in the next few months? Do you want to return to school or at least try it, communicate and socialize, work or become more independent, and then link over what's the problem? Why can't you do it? I'm not saying, I'm not putting blame on you. I'm trying to understand. Is it the voices that are still there, that you're paranoid, not wanting to leave the house? Is it that you would want to, but you feel blah? Why even attempt it? You can't even have anticipatory joy anymore. Or is it, I can't concentrate. I can't put two and two together. How on earth could I organize myself to go to school or even be successful at tests that I usually was doing fairly easily? So what does then the clinical research tell us, and what might be utility of digital therapeutics? So there are different approaches to treat people with mental illness. There is obviously psychoeducation and other psychological or behavioral approaches. That should always be one bedrock of our initial treatment. Then if that's not good enough, then we would go to pharmacological approaches, particularly if there are not only symptoms, but there is also distress or dysfunction, and the symptoms are severe enough to lead to that. But now we have a new era where we may even be able to bring to bear digital therapeutic approaches. Why are these potentially important? Because we have a shortage of mental health practitioners. And there are areas in the United States and other areas of the world where there's a shortage of people who can deliver high quality and evidence-based care. At present, there are no FDA-approved medications for negative symptoms or cognitive impairment associated with schizophrenia, and that those are the primary drivers for lack of functionality. And here we may want different treatments, both pharmacologic, but potentially also treatments that are packageable in the digital world. So what do the authors of the European Psychiatric Association recommendations say for CIAS, which is cognitive impairment associated with schizophrenia? In terms of pharmacological treatment, the evidence suggests don't give first-generation antipsychotics. They block dopamine too much. You have too much of a likelihood of having secondary cognitive symptoms. For patients who have a second-generation antipsychotic, once you've switched them over from a first-generation agent that may cause secondary cognitive and maybe negative symptoms, there is no winner that one atypical antipsychotic is better than the other, although we would say having less EPS or sedation or weight gain may help cognition. There are current treatments in development that focus on cognitive impairment associated with schizophrenia. I mentioned earlier when talking about the NMDA glutamatergic system that glutamate alone doesn't really set things into motion. You need a second component, which is the co-agonist, and glycine is one of them. We've tried in the past to put glycine or D-serine into big milkshakes and elevate the blood levels. It doesn't seem to work well. But another way to elevate the glycine levels in the synaptic cleft is to block the reuptake after glycine has been released into the synaptic cleft. And iclopertin is one such drug that is currently in phase 3 development in the CONNEX 3 trials to see whether the phase 2b study that was positive can be replicated by adding on a glycine transporter inhibitor, thereby improving cognition and hopefully also functioning. RL-007 is quite interesting because it's a GABA B receptor agonist helping cognition. It's an NMDA receptor agonist, that's the glutamatergic pathway we talked about, as well as a nicotinic receptor agonist. We know that alpha-7 nicotinic receptors are involved in cognition, and people may have different deficits in these neural circuits, and maybe by having a triple targeting agents, there could be good effects. But this is being studied at the moment. And there are others that have to do with either nitric oxide signaling pathway, dopamine 1 partial agonism, but also the most recently approved drugs are normally in trospium, which is an M1, M4 agonist on the muscarinic cholinergic system, plus a peripherally restricted anticholinergic trospium. That M1, M4 component, especially the M1 stimulation in the frontal lobe, has shown to be good for cognition in Alzheimer's disease in the 90s, and in the 3 phase 3 studies, or the 1 phase 2b and 2 phase 3 studies that led to FDA approval in September 2024, there was also a cognition subtest, and that was significantly better than placebo in the subgroup of patients that had at least one standard deviation below the population norm in terms of cognitive impairment. Now, this was in acutely ill patients where positive and negative symptoms improved, so that could be pseudospecificity, even though in analyses it didn't look like that. The European Psychiatric Association also recommends psychosocial interventions for cognitive impairment associated with schizophrenia. One very effective treatment, at least in meta-analyses, is cognitive remediation that's recommended for the treatment of cognitive impairment in people living with schizophrenia. The problem is it's not always followed through for long enough because it might get boring as a computerized program and it may not be gamified enough. Social cognitive training is also recommended for the treatment of social cognitive deficits, and the cognitive remediation works best when it's embedded in a rehabilitation program and also combined with trained therapists. It's called blended care. We know that aerobic exercise helps both the heart but also the brain. It's not stamina exercise, it's aerobic exercise, so cognition improves. Interestingly enough, especially team sports is very good for social cognition. So here you have to mix with people, you have to understand where to throw the ball, meet their eyes. So the effect size was actually twice as high for social cognition in physical exercise that involved team sports than in the usual cognition. And then lifestyle interventions means that you have healthy diet, no drugs, and also trying to keep a healthy weight may also have some effect on cognition in a positive way. Now, pharmacological treatments, we may treat with antidepressants. They have about an effect size of 0.30, 0.35, even when patients say they're not depressed, but the data are not very consistent. And we also want to obviously get the secondary negative symptoms under control. Whether a trial of clozapine should be considered in treatment-resistant patients is unclear, but once you improve positive symptoms, you can improve also negative symptoms. Try to not use anticholinergics. I think that is very important because that can further worsen cognition. Currently, there's only one agent that is still possibly in the running for negative symptoms. It's called roluperidone, which is a 5-HT2A antagonist and also a sigma-2 and alpha-1A receptor antagonist. But it's a monotherapy, and we don't know whether it's actually an antipsychotic. So you wash out antipsychotics, you give this for negative symptoms, and it worked in phase 2, but not in phase 3. So we'll have to see whether this has a future or not. Looking at other psychosocial interventions, we could use cognitive behavioral therapy when there's depression that may be associated with cognitive problems or negative symptoms. We also could use CBT for positive symptoms, which is adapted to the positive symptomatology. And in that case, by improving positive symptoms, you could also improve negative symptoms. Again, cognitive remediation has even a spillover into negative symptom improvement, but you see that the grade of recommendation is B and C and not A to B as for cognitive impairment with those psychosocial interventions. Let's go to the last chapter now and evaluate how digital health applications and the use of digital technology could potentially help, particularly people with schizophrenia. Now, what is digital technology? It's something that measures health behavior in daily life, so ecologic momentary assessment, which is great. You get a lot of granular information, how people function in their own habitat and not just retrospectively in the office. How did you feel in the last month? There are also intervention opportunities anytime and anywhere. And it's if you can plug it in or run it with batteries, it can be digital health. Now, there are different parts of this, independent or complementary digital therapeutics based on foundational research, but not all healthcare applications have evidence base to be for therapeutic use. So as you know, there are all these wellness apps that have no data behind them, only proprietary. But there are digital therapeutics, but there are also prescription digital therapeutics. And those have to be FDA approved and need to be shown to have efficacy over the usual approach. Now, what are SAMDs? Those are softwares as medical devices. Those are prescription digital therapeutics. They have to be cleared by the FDA. They have to be evidence-based, meaning there is a study where a comparator was basically beaten. It's software-driven and is indicated then by the FDA to either prevent, manage, or treat a disease or disorder. And the prescription digital therapeutic has to be both effective but also safe. So that's about data protection, but also that human errors cannot turn this device against the patient and their outcome. There are different regulatory pathways. There's a wellness app versus software as medical device. So when you want a digital therapeutic, you really have regulatory oversight. If not, then it's a wellness app. You need to enforce discretion. There needs to be a different either 510K submission, which is you're applying something to a treatment that's already out there, or it's a de novo pathway. But it's good that we have now regulation, which also means there's reimbursement possible for digital prescription therapeutics. Now, generally in Medscape, we do not use proprietary names, but since there are different approaches to these digital therapeutics, in this case, we have to name them because otherwise it would be totally unclear what we're going to talk about. And here are digital prescription therapeutics that are FDA cleared that you can use now. Maybe you didn't know that, but it's possible. So there are different diseases where this works: ADHD, PTSD and nightmares, major depressive disorder or postpartum depression, anxiety, but also insomnia. And on the left-hand side, you see what this is called, Endeavor treatment or over-the-counter. There's one that's you have to pay yourself. The other one can be prescribed. Nightwear, Free Spiral, Rejoin, Mama Lift Plus, Prism, Daylight treatment, and Sleepio treatment. And you see what actually are the ingredients. So it's either attention through an evidence-based protocol and some almost like a video game. There are other treatments that have been FDA cleared but are not yet available and are looking for basically being distributed by a company in order to be made available. So how do digital therapeutics address gaps in our traditional mental health care that we will always be in, but this is an addition that can maybe help us? Well, there's greater accessibility. As I mentioned before, there are areas in the world and in the US where there are few therapists or psychologists or psychiatrists. You also may bridge the gap to the next appointment when there are waiting lists, and it's scalable. Everybody who has a smartphone or access to the internet can actually do that. You may reduce stigma and barriers because there's a lower threshold. I don't want to talk to a person, but maybe with this app, I can more easily address my problem. Disparities can be also reduced because it's so scalable. Everybody should have access. And also transportation barriers can be addressed. A number of companies are investing, which is also helpful for the economy. And also research comes out of it, which then helps us to define best practices. In terms of treating patients with psychosis, nothing is yet approved, but there are ongoing developments. One is called the ActAssist program. That's for early psychosis. It's CBT based. It's a smartphone intervention targeting hallucinations, paranoia, perceived external and internal criticism, socialization issues, and cannabis use that can drive psychosis. It's a 12-week single-blind study, 36 patients, and people actually completed the study. 97% and 75% were active daily. Obviously, this is a little bit artificial because patients sign up for the study, they want to do it, and also they get reimbursed for it. But here, with the exposure through the digital therapeutic, there was improved negative symptomatology, and also general psychotic symptoms were improved, as well as mood. And this was a university-based trial. Another one is CBT to go. It's a blended CBT-based care for patients with schizophrenia. Blended care means it's not just the device, it's also a coach or someone who's accessible and can help the patient or reinforce the CBT. So it's a 12-week intervention with a 24-week follow-up. You see this is now much larger, 255 patients, 3 arms, single in-person CBT session, and then delivery via the device, or the second group, a single session of illness education and self-monitoring, which is above tau, but it has at least the same ingredient of education, and then treatment as usual is the other comparison. And the outcomes here are negative symptoms, self-management, focusing on defeatist beliefs, adaptive beliefs and behaviors. And here, the reductions in negative symptoms were evident after 12 weeks, which actually achieved a Cohen's d of 0.55, which is a medium effect size, which is pretty good and would lead to approval of a medication. Again, a university-based trial. Motivation and skill support. It's a smartphone intervention for patients with schizophrenia that has CBT and social skills training elements. It's smartphone-based. Outcome is social functioning impairment as well as social motivation deficits. It's a standalone open trial, 8 weeks of therapy and 3 months of follow-up. It's again small, 31 patients. And here, improved social functioning was seen with a Cohen's d of 0.4, improved positive symptoms of 0.45. But these gains were not maintained at 3-month follow-up. They were only present during or at the end of the 8-week therapy. And then there is CT155, which is a smartphone app for treating schizophrenia. And there's a series of trials trying to get this through the FDA approval. There was an exploratory study that provided insights that could be used to modify the intervention. It's very important to deliver these interventions after you've had user input so that you basically make sure users want to use it, can use it. And now there's a multi-center exploratory single-arm trial that was also completed. And finally, a 16-week multi-center RCT where 2 different prescription digital therapeutics are assessed as adjunct to treatment as usual, standard of care. And after that is achieved, then open label extension follows that, because the question is, do you sometimes need a booster, or do you need 2 sessions or 2 interventions in order to get through certain subgroups of patients? So the features of a supported system of care, where this is embedded into digital therapeutics, has several fundamental components. It's an integrated multidisciplinary approach. A case manager is available and in regular contact so that people are not left to their own devices, so to speak. It has to be a flexible system, and also ideally would involve families, because we know when patients are connected to families, the care is better, the adherence is better. Blended care, I mentioned already, has been helpful in both mental health and substance use disorders. It means that you integrate digital and traditional psychotherapies, and you can dial in and out and up and down the blended component as much as necessary, but obviously you keep the scalability of the foundational digital prescription therapeutic. It bridges between fully digital and fully in-person therapy, and it also has improving access to psychological therapies component, which was successful in integrating these 2 elements of care in UK primary care settings. Ideally, the adoption and access issues are addressed, but they can persist. And the question is, how much can we improve effective and efficient care? Health equity and limitations for use have to do with access to technology, whether there's broadband and internet data use, and they may be limited due to cost, location, or other reasons. People may not have a social environment or living environment where they can keep a smartphone. It might be stolen from them. Digital and health literacy, which is in younger patients much less of an issue, but what about maybe older patients who may not understand how to use the digital platform or may not feel they want to engage with it? There may be cultural and language barriers. Obviously, languages are easy to translate nowadays, but still it may not be acceptable in all cultures or be available in those languages. And then finally, the affordability. But we would hope that with evidence of improved outcomes, then there could be also insurance coverage, but there may not be insurance coverage everywhere and for everyone. How would you determine the success of the digital medicine program? Well, it has to do with how often do people come and use this? What's the patient input? Are they happy with it or not? And also, what's the provider experience? When the provider feels overwhelmed, they can't explain it, it's not easy that they can basically prescribe it in the medical record or on a website, and then it's not going quickly to the smartphone of the patient, and there's a video or an introduction, and they have to do too many things, it's unlikely to be implemented. Clearly, clinical outcomes will drive our appetite to do this, as will the ease of use and the financial pluses and minuses. Are we saving money? Are we saving ultimately time? And again, do we have an increase in equity and inclusion? What are the main takeaways? Negative and cognitive symptoms remain clearly a huge unmet need in the treatment of people living with schizophrenia. The burden of negative and cognitive symptoms often coexists, and one perpetuates the other or at least enhances the other. Pharmacological treatments for these symptoms, negative and cognitive, are on the horizon, but currently nothing is approved for them, and hopefully this will change in the near term. However, digital therapeutics and digital prescription therapeutics that have a higher level of standardization and also quality of the digital prescription therapeutic and clear data to back up their efficacy and safety may address negative and cognitive symptoms when added to standard of care options. Well, I want to thank you for participating in this activity. I hope this was helpful and also will hopefully inform your care of your patients. Find useful tools and resources also on the right-hand side of this page, and we thank you for your participation.